So greetings. So first of all, let me thank everybody for joining and my panel, Selvi, Roy, Sylvia, Sriram, and also Dr. Graham. Thank you so much. Emil, good to see you here today. And I want to acknowledge my mentor, John Stoline, for his support, Mr. Charles Butt for the grant, Angela Deal for the illustrations, and my institution, MD Anderson Cancer Center. So I want to share with you, this is an interesting problem that I dealt with. And also we will learn a lot from Sylvia's part of the world, I think in this case. They're from Netherlands. They've done a lot of good work in this area. So this is actually a 50-ish, 50-year-old woman. She was sent to us for EMR by a colleague of mine. And in 2018, when he performed a colonoscopy, his findings include a descending colon 6 to 8 millimeter polyp times 2, cold biopsy done, cold biopsy polypectomy. Pathology was tubular adenoma and a serrated adenoma. And then in the transverse colon, there was a 15 millimeter flat lesion. Biopsy revealed a Cecal serrated adenoma. He decided not to resect, and he placed a tattoo. And in the hepatic flexure, there was a 9 millimeter flat lesion. Cold biopsy was done. Cold biopsy polypectomy was done. Again, a Cecal serrated adenoma. And in the sigmoid colon, there was a 10 millimeter sessile polyp. Hot snare was done, and it turned out to be a Cecal serrated adenoma. And in addition, internal hemorrhoids. She was otherwise in good health, not on any medications, and her family history was significant for both her uncles, right, on the maternal side and on the paternal side. Had suffered with colorectal cancer, and her sister has a history of colon polyps. So why don't I do one thing? Sylvia, what do you think with this story?
I think this is very suggestive for a serrated polyposis syndrome, given the multiple serrated lesions, Cecal serrated lesions with or without dysplasia, and a family history of colorectal cancer. So I did not apply the WHO criteria yet, but if we have more than 5 serrated polyps, of which 2 in the proximal colon, of which 2 are larger than 1 centimeter, or more than 20 polyps, serrated polyps throughout the colon, then this patient would meet the criteria for a serrated polyposis syndrome. But again, I'm not so strict. Sometimes they just are borderline cases, and if we observe them over time, they meet the criteria. So I think that's very suggestive for serrated polyposis syndrome.
Right. Thank you so much. I think what I wanted to do is I just wanted to review this. I know, like Sylvia talked about, the first, I think WHO came up with the criteria in 2010. At that time, they included family history. In the 2019 one, they excluded that. And other than that, you heard about the criteria from Sylvia. Basically, more than 5 serrated polyps proximal to rectum, should be more than 5 millimeters in size, with 2 of the polyps more than 10 millimeters in size. And then the second criteria was a bunch of serrated polyps, more than 5 millimeters proximal to the rectum. And when I say bunch, 20 plus. So it's also interesting. I started reading a little bit, and I was wondering, I keep thinking myself, and I'm a fellow of Dr. Graham, although I didn't make it there, but I thought I should do some groundwork. So it's very interesting that serrated polyposis is the most common polyposis. And I was looking at some of the work. If you look at everybody who had a positive fecal occult blood test, it is about 0.9% of that population. And then if you look at people who are coming in for just colorectal cancer screening using colonoscopy, then it's about 5.5%. So it is quite common. And one thing is we should consider that we don't do is with EPIC, we should take the pains to document on the front page of EPIC every colonoscopy and all the polyps there, so that at one point in time when we are doing the next colonoscopy in a patient, we can actually look at what happened to that patient's history and maybe find out who had serrated polyposis, because this diagnosis is often overlooked. Selvi, any comments on that?
Sure, Raju. I actually took your advice when you worked with the EPIC team at MD Anderson and made it possible for us to document endoscopic findings in the front page or the patient summary in EPIC in our medical record system. And so I don't do that for all patients, but I do that for my high-risk patients. So my patients with either Lynch syndrome or FAP, I do a little summary blurb in there of what I found on each of the exams from year to year.
Right.
I think another comment.
Go ahead, please.
Go ahead.
No, you go ahead.
Well, I was going to talk about something else.
You can make that.
Okay, so the other thing is, and you may get into this in the rest of the presentation, is what a challenge it is to detect these serrated polyps or sessile serrated polyps or lesions endoscopically. And so I hope that we'll talk about that a little bit. We know that these sessile serrated polyps make up for about 30% of all polyps, and the majority, 70%, are made up by adenomas, tubular adenomas most commonly, and that cause colon cancer. So 70% of colon cancers come from tubular adenomas or adenomas, and 30% come from these serrated polyps. So it's dangerous to miss them, and I think there's some tricks to be able to detect them and remove them completely. That's all.
That's good. Thank you. So what I thought was I basically want to share with you what happened with this lady. The first colonoscopy was done in March 2019, and that was when she was sent to us. It took about 56 minutes. We did 4 EMRs, as you can see here. This was the lesion that was removed, and we injected, we lifted, we cut it, and there was another lesion here in the ascending colon. So one thing is I want, for the sake of fellows, I want to make a comment that we should take time to document well. And it's not just a written document, but also get into the habit of, say, for example, ascending colon EMR images 4 to 8, right? These tell the story about this polyp. It's a good idea for somebody looking at your report to figure out what image goes, what are you talking about in your report. Again, here, 9 to 17, talking about this polyp. So get into that habit. So we basically removed several large polyps. And then we found that this woman had a lot more polyps, and I could not remove. I basically documented and felt that we should bring her back. All these polyps turned out to be sessile serrated adenoma. So here, these are the polyps. I put it here, they're saying that not removed, and made a note of that. Roy, any comments?
I have a few comments. I'm not aware that 30% of colon cancer is from serrated. I think serrated is an overrated kind of disease. You know, some people wanted to just put it on the map. That is like an important thing. There is really, I'm not so sure if that's true. I've not known the data. I think serrated is important when it has developed into dysplasia. When it has dysplasia, then it's dangerous. But other than that, yeah, sure. You try to cut it, but there are like other things that are equally, if not more important and much more commoner, which is like the flat adenomas. Like for example, when you talk about this polyposis being 0.5%, I mean, depressed lesion is also 0.5%, and the flat lesions is a lot more than that. And the last thing I wanted to comment is that when a patient has serrated polyposis like this, it's really quite difficult to find their lesions. And the easiest is really to just do a chromoendoscopy exam, and then all of these lesions will just like pop up in front of you, and you don't have to really force your eyes trying to find them. Even when you force your eyes, we've had that experiences whereby we actually couldn't find them. So the easiest is just like spray the entire colon blue, and then they'll just show up.
Good. So one thing is I want to ask both Sylvia and Selvi, given their interest in high-risk cancer syndromes. When I made a comment about 0.5 to 1%, that is 0.5 to 1% of the patients coming in, and it is more common than other polyposis. So let me ask, what is the prevalence of female FAP? And what is so in terms of the polyposis? So that's in that regard, I made that comment, 0.5 to 1% this is the most common polyposis.
Yes, I'd like to comment on the questions. I think the first point is that serrated polyposis syndrome is not a hereditary colorectal cancer syndrome. It has been grouped together with these syndromes just to increase awareness and to help to improve our understanding, but there is not now any known gene mutation, not yet identified maybe, associated with serrated polyposis syndrome. So it's not a hereditary colorectal cancer. We see it sometimes in familial clusters, but there is no genetic background. And regarding the prevalence, I will echo Roy's statement. Altogether, the polyposis syndromes account for less than 1% of colorectal cancer. So they are all rare conditions. When we look to the hereditary in general, the most common is, of course, Lynch syndrome, and it deserves more attention because these are really fast-growing lesions. Serrated polyps are difficult to detect, of course, and I think that chromoendoscopy, as Roy pointed out, is helpful in this case, but they are not fast-growing lesions. Clearance at the index colonoscopy is very important, and of course follow-up intervals of 1 to 2 years while waiting for more evidence that these patients really have a very high risk for colorectal cancer. I'm also not sure I know the literature which documents the association between serrated pathway and 30% of the colorectal cancers. This is mentioned in some editorials, but there are no real data to support this, in my understanding, at least.
All right, that's gone.
And maybe just one short comment regarding the chromoendoscopy for serrated polyposis syndrome. The 2019 ESGE guideline adopted a pancolonic dye-based chromoendoscopy for serrated polyposis syndromes, because as we know, these patients have small and flat appearing lesions. So that's the reason to better phenotype them using chromoendoscopy.
Okay, that's good. Thank you so much. So you might be wondering, why the heck did I put this picture here? And as you can see here, under the long-time loyalty, you see Mr. James Baker. He has done a lot of good work for Texas as well as the United States. I'm actually reading or listening to his biography, so I was really fascinated listening about his early part of his career. That's where I am. So if you guys are interested, this is a fantastic book to listen to or read. So we did the first procedure in March, and then we started, okay, there are several polyps, we need to bring her back. Within a couple of months, we brought her back. Again, it took about close to 79 minutes. And this time we removed about 6 polyps. Again, all of them were done as an EMR. So here is a lesion. We lifted and we cut it, and then we closed it. This is another lesion. They're subtle. We cut it again, closed it. Another lesion, cut it, closed it. And again, another lesion, lifted, cut it. So one of the things that, for the sake of fellows, I want you to keep in mind is, get into the habit of documenting your story about a particular polyp, right? You want to document what you see and what you've done and what was the end result. Like say, for example, the lesion is here. You show that the lesion has been lifted and this has been cut, so that you get into the habit. I think it's a good habit to get into so that you can tell a complete story. So we 6 polyps, again, all of them serrated adenomas, and then brought her back again in a few months in December. Again, this time about 15 minutes. This time we removed 7 serrated polyps, right? So, and then the scars from the previous resection basically looked good. They had no recurrence. So, all right. So that's the story until 2019. And then this was done just a week ago, and I wanted you to see this. And Roy, do you see anything there?
I see it near the appendiceal opening, but I want to emphasize that more likely than not that this is not a de novo metachronous lesion. Unfortunately, this could have been, and if I have this case, I would think that this was unrecognized lesion that was there. And this again speaks to, it's not I'm saying that you had missed it, but I'm saying that when you have so many big lesions and you have to cut them, you also have to like look around. I think as an endoscopist that we will face into cognitive overload. And this phenomenon has been documented, for example, when people cut big lesions and they go back like 3, 4, 5, 6 months later, they actually find, oh, wow, there's another lesion that I had missed. And now, you know, one wonder, wow, really they missed something like that big? I think one of the reasons is this cognitive overload. And you were like overwhelmed with, oh my God, as you go in, it's like, oh, there's a lesion here, there's a lesion there, and then you started looking. And then there's this lesion that is linear here on my view. And you were so, like there's too much information and this lesion is just like overlooked. I think what I want to say is that serrated with dysplasia is the one that grows fast. These other serrated may not be.
Yeah, that's right. So one of the things, I want to make a point for the sake of the fellows here. When you see serrated polyps, right, your goal is to remove the large ones, and the ones, they have a nodule or something, that is, even if it is small, that's the one you should cut first. Because serrated polyps are flat without much of features. And if they have a nodule or whatever, that means they have a dysplastic component. And once dysplasia develops in a serrated polyp, it goes to cancer very fast compared to traditional adenoma or a regular adenoma. So I tell patients that, okay, you have serrated polyps. My goal is to clear your colon, and I'll go and take out the worst one first, and then the big ones. And then the smaller ones I may see, and if I see them, I just make a note, but I don't really cut. And we try to clear your colon before we go to the so-called surveillance. The surveillance doesn't start until you have cleared the polyps, at least 5 millimeters or more of all the serrated polyps in the colon. So you can see this lesion, right? And I want to show you something, right? I thought it is a small lesion. This is not the lesion you want to cut with a cold snare because you don't know where the borders are and how far it extends. And don't get into the habit of cold snaring because you felt that it is easy to do, but you want to define the entire border. And the only way you could do that is by injecting. And as you can see, once we inject, you actually see that there is a lot more to it than what you first thought about.
Beautiful.
Sriram, any comments?
I agree, sir. That's so beautifully demonstrated the size discrepancy after you inject, and it, especially when the lesion is closer to the appendicular orifice, it can that carpet can extend into the orifice.
Right.
So it is your comment is as much more valid in these kind of lesions, because imagine if this lesion was elsewhere, and if I mistakenly thought that it was a smaller polyp and did cold snare, subsequently, if I recognize, I can extend the resection. Whereas if it is in this location, the risks become much more. So from this beginning, to adapt a method where to define the margins before we snoop on it is very essential. I agree that.
Right. Okay.
Raju,
Yeah.
may I interject?
Yeah, please.
I used to lift all of these, and I found that I actually, it was easier to remove them without lifting them initially, because there was more give to the mucosa, and I think that I spend less time and do a better job. I will say also that I have long, you know, we all do this ourselves. We touch up around the polypectomy site often. These are the ones where you have to be very, I'm more careful at making sure that I do a good job of touching the periphery, and that helps a lot with any kind of recurrence. This
Right.
particular one is challenging because there's complex angulation and curves to it. So I understand completely why you wanted to lift this one, but I just wanted to say generally that I found that even the ones that go into the appendicular orifice, I can get a really nice angle on it. And by pushing down on the mucosa, get a good grasp using the snare alone.
Right. Thank you, ML. Thank you for that nice comment. I think it's important to keep that thing in mind. So I was actually talking with my colleague yesterday, I think Joseph, and we were thinking about, okay, whenever you see a lesion close to the appendix, you want to make sure that it is not going deep into the appendix. And that's one thing. If it goes deep into the appendix, what would I do? I cut what I can. And then what is going into the deep into the appendix, we may need to get a surgeon to remove the appendix along with the cecal base. And that's what you may need to do. So just something related to lesions close to the appendiceal orifice, how to do that. So we went ahead.
Ju, can I ask a question?
Yeah, please.
Would you do that and refer the patient to a surgeon, even if the lesion that you did remove did not have dysplasia, if it was free from dysplasia?
So
Would you
if
still
I,
do a surgical referral?
if I see a lesion like a serrated adenoma that is going deep into the appendix,
Mhm.
I've seen maybe probably about 4 or 5 in the last 10 years.
Mhm.
I sent all of them to surgery. And one actually had, none of them had anything other than just serrated adenomas in the appendix. And they do a Cecal-based resection and they're out of the hospital in 24 hours. Only thing is you should tell them that it's not just appendectomy where they leave a little bit of tail, but to get the cecal base so that you don't have to worry about whether there's anything left. I had one patient who had a polyp at the appendix orifice that turned out to be benign, but deep in the appendix, there was a cancer. So I don't know, because this is not written in the literature, what to do with these lesions.
Based
And
on case report. Yes.
yeah, I feel that, okay, in somebody who's otherwise healthy in 50 and they have another 30, 40 years of life or 50 years of life. Yeah, if you think about the biology of the tumor and expect that they will grow, it's better to get it done when they're still healthy. And the appendix surgery is not that big of a deal compared to right hemicolectomy down the road.
Mhm. Thank you.
So in that regard, I want to make one more point. When I always go, actually, we'll ask Joseph to bring his video maybe whenever he's ready with that. I always look at the appendix and I try to use my cap to open the appendix and examine. That's what I think that you reach the base of the cecum. It's not like a cecal base photograph from the top of the ileocecal valve. I try and kiss the opening of the appendix. And I've seen several serrated adenomas in there. And I ask myself, is it extending into the appendix or not? If it's not extending into the appendix, I will try to remove. If it is going into the appendix, I will do my best to take a lot of pictures to document that is going into the appendix and take a biopsy to show that it is truly something abnormal. So that's what I do. And if it's going deep into the appendix, the next step is I send them to surgery. Okay, so here we actually did if you see that, although there is a nice clear-cut lesion, there are some, you will see later, there are some satellite lesions in this area and then to the right side. And this one, we thought that, okay, we want to put the snare here, right at the opening of the appendix, so that we can actually get an en bloc resection. And as you can see, what is happening is, let me take it back here. If you look at it, in this area, the fluid is not bulging out, right? It's actually forming a valley. And you are likely to fold that if you put your snare here. So instead, it's better to put your snare here and anchor it, and then open to the right side, so that you could actually get that whole lesion in one piece. You can see that I'm anchoring onto the right side rather than here. So something to keep in mind. You know, you want to look at how the lift of your, how did your lesion lift, and then plan your placement of the snare based on that finding. So we used a stiff snare, and when you ask for a stiff snare, I always use a Olympus Snare Master. And now Olympus also started developing Snare Master Plus. That is a cold snare come hot snare. That is not as stiff as this Snare Master. So you want to, when you say Snare Master, sometimes the assistant may not realize, and then they pick up the Snare Master Plus, and you will not be able to get this like the way we are getting, because that other snare is not as stiff as this one. So keep that thing in mind. So here we used Endocut Q 313, and when in the cecum, I try to tighten it, and if I know that I got a lesion, just a mucosa and submucosa, and not trapped a muscle, I cut it fast, because by cutting fast, you're not applying too much of energy. And if you don't have too much of energy, there's less of deep thermal injury. And as you can see here, although the edge looks good, here there is something else, right? You see that, right? There is some residual lesion. It's not a complete resection. So what we did was we tried to get that thing with the snare, and thinking that we should be able to remove that. The problem is, you'll notice that when the instrument is too big for a lesion, you'll not be able to get it out nicely, right? You can see this. I thought that I got it nicely, but it tends to slip. Right? See, there is still. So I basically, when I see a lesion like that, I don't jump in and get my APC and burn it. I try to remove everything that I see as abnormal. Don't want to take any shortcuts. So here we're trying again the snare slips, and maybe if there was a smaller snare, maybe that would be useful. So in that case, I just use a hot biopsy. And when you use a hot biopsy, you need to change your electrosurgery settings from Endocut Q to I. And of late, I've been using Endocut I effect 1. That means there is no coagulation. It's a pure cut. And then duration, I put it to 4 so that there is a longer duration of cut. And then interval, you can put 1 or 6. It doesn't really matter. So you can see that now we got the whole thing out. The margin looks good. And you'll notice a few more things, right? So for the sake of discussion that we're going to have, I just want to finish this case doing APC. And here we basically set 0.8 liters of flow, 35 watts. You know, that's what I use for all of the ablation. And then I used a forced APC. So and I want to see that there is a browning effect, because that browning effect is going to destroy all the cells, at least the mucosa for sure. So you see that, right? I rotated my scope. And this is what I want to share with the fellows. You know, you should be able to rotate the scope in the cecum almost 360 degrees. And if you can do that every time you do your screening colonoscopy, that technique will help you when you're dealing with an EMR. When you want to rotate your scope, you get those skills easily. You know, you can apply those skills that you develop every time you do a screening colonoscopy. Try to see if you can rotate the scope in the cecum 360 degrees. So as we see this, right, it was completely resected. It's not a big lesion, but it is close to the appendix orifice. And now I see something else here, right? And there's a small area here, and there is another small area that you would see here. And if I do an EMR, if there are things that are in that vicinity, separate from that lesion, I try to remove them for 2 reasons. One, it can be done easily. Number 2 is, when you close the defect, those lesions will come closer to your scar, and you don't know whether that lesion that came closer to the scar is a recurrence or a separate lesion that you overlooked. So you can see whatever is looks a little bit odd. I thought that, okay, that small area looked a little bit odd. So we're removing it with a hot biopsy. Okay, so you'll see some hot biopsy avulsions. Basically, you pull back. You want to make sure that your device doesn't contact the adjacent mucosa because that will burn. So I see Aman. Aman, any comments?
I'm sorry, were you asking?
1 second, I think I saw Aman Paul. Yeah, probably it's gone. Aman Paul, you want to make any comments?
No mic.
Okay, that's fine. Roy, any comments?
Looks good, but there are more lesions popping up. It's like there's a lesion on the left to your forehead.
Yeah.
May I have a comment?
Another
Uh,
one at 12
As
o'clock.
we have, we just looked at the WHO guidelines. I mean, lesions which are larger than 5 millimeter should be removed in the same session. But actually, very small lesions indeed can be left in situ just because it's a matter of cognitive overload, as Roy pointed out. I think that's the real situation in this case.
Yeah.
They're growing that fast. They're growing in front of our eyes.
So Roy, explain to me about cognitive overload, because that's too big of a term for me.
Cognitive overload is basically
Explain it like for a 10th grader.
so there. It's hard to explain it. Cognitive
Yes, I have an
overload.
explanation for just what
Cognitive overload is just like you are like there's so much information coming at you. Some of them are real, some of them are noise, and at some point there's just too much noise, and then the real one it cannot be deciphered anymore. But I'm sure there are other causes. Like in here, you're just like feel like, oh my, this one lesion, there's another lesion, there's the third lesion, and you're looking at them, and then at some point, you really cannot recognize any more lesions. I don't know why that happens, but I know I've had experiences like that and things like that. So that's why when people say we are just going to do one resection for your big lesions and then you can come back in 2-3 years, yeah, maybe you cut the big lesion, but there is this part where people don't talk about, which is like during that cutting you're not recognizing anything else. So that's I think a concept. I'm not very familiar with like psychological stuff, so I feel overloaded when you ask me something like that.
In Texan, we just call that an excuse.
Professor Raju, may I have a comment?
Please.
What I usually tell, it's about the cognitive overload. So how do I explain it to my trainees? I say, when you drive a car, you have to focus on the way, on the traffic lights, the car in front of you, the car who's following you. You can't see all the details. You can't see the flowers, you can't see the trees. It's just first things first. of course, all are important, but we start with the most important lesions and we remove the largest ones, which are important for the prognosis and the follow-up of the patient. And then after we remove in a second look colonoscopy, those smaller lesions.
Yeah, that's good to hear. Yeah. So now that I understood what you guys are talking, this is what I tell my fellows. If you're looking for a job, don't look at 10 things. Ask yourself what is your top 1 or 2 priorities, and just if they fulfill that, go for that job. Because I can see some of my fellows looking at 1,000 jobs and can't figure out what to do. All right, so we close the defect, as you can see, and one other thing that I want to share with you is in this patient, I actually cut another 5 polyps. I didn't show you. And sometimes what happens is this large piece, right? You can see this, you cannot suction that through a pediatric colonoscope. And even adult colonoscope can be hard to, even with an adult scope, it might be hard. So off late, what I've been doing is, this is what I've been doing to get that polyp back. So what I do is I take it into my biopsy port or the clip, fold it so that it becomes smaller, and then pull and also apply suction. So that way, at least I'm able to clear the polyp and I don't have to come out with a net and then go back, because in this patient, I had to go back and cut some more polyps. So something to keep in mind. And if you know that it is a clean serrated adenoma, there's no dysplasia or whatever, and you cut a large piece and you have to cut some more polyps, in those cases, I may use a snare to cut the serrated polyp into 2 pieces and then suction them out. Something to keep in mind, to get the job done. And especially if you reach the cecum with a lot of difficulty, these small tricks will help you. So this lady, as I said, I had to cut another few polyps. So I decided that I will put they use the clip that the last clip I wanted to apply, where I removed with the heart biopsy so that she doesn't bleed. And we close that with close the defect with the clip. And okay. So this time, we saw the Cecal polyp. In addition, I cut 6 more polyps. Took about 87 minutes, and they were all sessile serrated adenomas. And I wanted actually, for some of the fellows here, I want you to read. There are 2 good articles that came out. Both came from Netherlands, actually, where Sylvia works. This one came from Amsterdam. One came in gut and one came in GIE in 2020. And this was a large study for 10 years of serrated polyposis. And what they've shown is, if you follow the protocol and clear the polyps, and then based on the findings of your last clearance, after you cleared, and at the end you said, okay, you cleared all the polyps, and based on the findings, if they have either large polyps or advanced polyps or multiple polyps, then you keep the interval at 1 year. And once you come down to none of these features, then you can increase the interval to 2 years. With that surveillance program, you could cut down the number of endoscopies. And they've also shown that the risk of complications, endoscopy complications related to managing these patients with serrated polyposis was also very, very low. Maybe one patient had a bleed and one patient had a post-polypectomy syndrome. Both fall below 1%. So this is a very good article. So, Sylvia, any comments?
No, I think that this is the protocol indeed. If the patient has at least one advanced serrated polyp or more than 5 non-advanced, clinically relevant non-advanced, which means larger than 5 millimeter, then they will come for repeat colonoscopy at 1 year. And if they have a low number of lesions and no advanced serrated polyps, 2 years interval is sufficient.
Yeah. All right. So now we'll open it for any discussion. I forgot to look at the chat. So Hazar asked me what type of clip did you use. I think in the first few clips, they were all microtech clips, 16 millimeter clips. And then the last clip was a resolution clip. So if I need to use a clip that has a better rotation that I can control, finer control, then I prefer the resolution. If I have a larger defect, then the microtech has 16 millimeters. Roy, any comments?
Maybe one comment from my
Yeah,
side. Do you recommend screening colonoscopy in first-degree relatives of these patients? Not so familiar with the most recent US guidelines on this.
I do.
Yes.
I do.
So according to the ESGE guideline, first-degree relatives of a patient with serrated polyposis syndrome should undergo screening colonoscopy starting at the age of 45 years every 5 years. So
okay, that's good. That's good to know. That's good to know. Yeah. Shall we any comments? Go ahead, Roy.
Patients like this, especially when they're young, I would say scares me that I might miss it despite really looking very, very carefully. So in patients like this, I insist that they, when they come back, they will have a chromoendoscopy to look up the flat lesions. Because in these patients, some of the lesions are actually the true 2B lesion, which is the completely flat, completely flush to the surrounding mucosa. And those lesions are very, very hard to see despite your best endoscopes. So you need help for them. Some people will say, well, why don't I just turn on the NBI? Well, it's like if you're not used to screening using the NBI, trying to do screening on the most difficult patient is really not the way to go. So don't have this false illusion, oh, this is the time to do NBI. No, it's not the time to do NBI because you've never done an NBI before. This is actually the time to just take up some blue dye and then just mix it with some water. And all you need is just like almost like a tinge so that you highlight the surrounding of the lesion.
Yeah, that's a good idea. Tell me.
No, Raju, I agree with what's been said. I think this was a beautiful illustration with some great teaching points. Thank you for sharing it.
Sriram.
I echo Dr. Sutekno's comment. I generally, because of it is not always the same endoscopist in the way we practice, who might this patient end up with due to scheduling conflicts or whatever. I try to make it a point in the comments in the report itself with the plan for next time to use chromoscopy or use an endoring or whatever additional measures that I would like to take to detect the missing or potentially missing lesions.
Yeah, that's good. I think, for the sake of patients, if you look at it, most of the screening that we do, they don't develop cancer. But for high risk patients, I think one person should figure out a way to include in the system to take care of them serially rather than jumping from one faculty to another faculty.
No. My point is in terms of making it a kind of a habit. It is stuff happens. I can forget or whatever. The person can change. The endoscopist can change. I'm just emphasizing the point of documenting in the report as to the plan for the next, so that nothing is missed. I agree to the extent possible. One should always follow up colonoscopy on their own patients.
Yeah, I think it's a great point. Thank you. Sylvia, why don't you summarize what we've learned so that I can put them in there for you?
Well,
Hold on. I think Ravi has something to say. Let's hear what Ravi has to say. Then Sylvia can close it.
Okay.
Ravi?
Hi. I just actually wanted to share a video of how chromoendoscopy would help in visualizing an SSA, especially in serrated polyposis. Can I share a video?
One second. Let me just make you.
Just make me a co-host so I can share it.
1 second. I'm trying to see. I'm trying to see where you are. Actually.
Are you just R? Or is your name here? I don't see a Ravi.
Ravi, are you R? Why didn't you talk?
No. Can you hear me? Hello? Yes. I don't think it's R. It must be Ravi, no?
It
It's
just
R.
has, there's only one R. There is no Ravi in the, as a, why don't we just make the R person the co-host and see if, there we go. You already did it.
It says you cannot start sharing while the other participant is sharing.
You can share now. Can you share now?
Yeah.
Okay.
Okay, good. He was R.
Yeah, so this is a lady, again, she came in for screening. And what we saw is something like this, which is like glossy, but not very clear. Then we spray the dye. We can see how big the lesion can be. And then the margins now start appearing more clear. So I think this blue dye, in fact, helps very much, especially in patients with SSA. It helps us to appreciate the margins, the extent. And this lady actually had a SSA with dysplasia.
Ravi, can you share us the white light before you put the blue dye? Bring it back to the beginning.
Let me see if I have that.
You may need to stop where we see the lesion. No.
Not this one. No. I don't think I have that right now.
Okay. That's a big lesion.
That's a big lesion. She had many such big lesions.
more
Okay.
time.
Very useful.
This is the one, I think.
Very nice. Please.
Oh, no.
So Emil asked, like, what is the concentration? Emil, the concentration is the same as for IBD. So it's about 2 ampule in about 250 cc of water.
2
That's what
ampules to 250 ml, right?
it's like so 2 ampules in 250 cc's.
That is 2 ampules of indigo or
Indigo.
of the
2 ampules of indigo.
Okay.
Okay, thank you.
Okay, thank you.
so much. Yeah.
I can.
Roy, why don't you bring a video on that so that at least we know
That would be
on
great.
how to do a chromoendoscopy with SSP if you have sections in there.
Okay, next week.
That'll be helpful. All right, let's wrap it up. I'll ask, let me request Sylvia to summarize so that I'm going to put a slide. Okay, these were the learning things.
Yes. So the take-home messages of this case could be clinical suspicion of serrated polyposis syndrome in this case was given by presence of multiple pale, poorly delineated lesions. In this case, think about carefully documenting the lesions, location, size, morphology, and resect all the lesions which are larger than 5 millimeter in the same session. Revise the pathology together with your pathologist to make sure which of them has dysplasia, which is only a hyperplastic polyp. Then an important lesson, consider at least the index examination, to phenotype the case using chromoendoscopy, indigo carmine, as most of the lesions are small and flat, and again, difficult to visualize. So indigo carmine or methylene blue can help you to better delineate them and phenotype the patient. And we have learned beautiful lessons about complete resection of these lesions. And I remember an US study, 2-center study, I think, in which MD Anderson was involved, and VA Palo Alto, if I'm right, where the recurrence rate after resection of large serrated polyps was very low, less than 5%. Please correct me if I'm wrong. And then follow up the patient with 1 to 2 years intervals according to the polyp burden and histology. And don't forget that the patient can have a sister, a brother, first-degree relatives, which may benefit from early screening.
That's beautiful. Thank you so much.
Thank you.
Really very well done. I'm really grateful to you.
Thank you.
Any other comments? Selvi, do you see any chat comments or anything that I can't see them here? Okay. All right.
No, I think we've answered all of them, Raju. There was one other question again about the settings, the ERBI settings for hemostatic grasper versus hot biopsy forceps.
So hemostatic for grasper and hot biopsies for cutting, not for hemostasis. We don't use it for hemostasis. And for cutting endocut with ERBI machine that we use, I use endocut I, effect 1, duration 4, interval, you can put it 1 or 6, it doesn't really matter. And for soft coagulation, either with a snare tip or with a hemostatic forceps, you use, I think, between 50 to 100 watts soft coagulation. You can use effect 2 or 3, whatever. Basically, it's the amount of damage is basically depend upon the duration of contact. So at the end of the day, how much you are pressing on the pedal for how long, that makes a difference. All right. I just want to thank everyone. I want to thank Dr. Graham, Selvi, Sylvia, Roy, Sriram, Emil, Aman. Thank you so much. Hope you all have a great Sunday. Thank you.
Thanks a lot.
Thanks, Raju. Bye, everyone.
Thank you.
Excellent session.
Bye, everybody. Thank you.